All right, let's jump right into the high-stakes world of perioperative pharmacology. Today, we're going to do a high-yield breakdown of 3 really critical classes of drugs that you'll see all the time in anesthesia and critical care. We're talking the absolute must-know stuff to keep patients safe. So here's our roadmap. We're going to start with adrenergic agents, the drugs that let us push and pull on the body's fight-or-flight system. Then we'll get into hypotensive agents for those moments when you absolutely have to get blood pressure down. And finally, we'll zoom way into local anesthetics and see how we block pain signals right at the source. Let's get to it.
First up, adrenergic agents. These are our workhorses for manipulating the sympathetic nervous system. They give us this incredible, fine-tuned control over a patient's heart rate and blood pressure right when it matters most.
At its core, this is a really simple idea. You've got agonists, which are basically the on switches. They stimulate the adrenergic receptors to make something happen. And then you've got antagonists, which are the off switches. They just get in the way and block those same receptors, stopping a response in its tracks.
But it gets a little more interesting when we talk about agonists, because they have 2 main strategies. You've got direct agonists like phenylephrine. Think of this like a key that fits perfectly into the receptor's lock. Then you have indirect agonists, like ephedrine, which are more like a foreman who just yells at the body to release its own keys, its own natural catecholamines, to get the job done.
And this is where you really see the precision we have. Look at this. Targeting different receptors gives you completely different outcomes. You hit the alpha-1 receptor with phenylephrine, and you get pure vasoconstriction, jacking up the blood pressure. But target the alpha-2 receptor with dexmedetomidine, and you get sedation. Or go for the beta-1 receptor right on the heart with dobutamine, and you make it squeeze harder. It is all about knowing your target.
Okay, so let's flip over to the antagonists for a minute and look at labetalol. This drug has a really unique, kind of balanced approach to lowering blood pressure. It's just a fantastic example of a drug with a really clever, multi-pronged attack.
So here's the crucial point. When you just dilate blood vessels, that's the alpha-1 blockade, the heart's natural reaction is to kind of panic and start beating faster to compensate. But levotalol is smarter than that. It prevents that panic by also blocking the beta receptors in the heart. That dual action gives you this smooth, controlled drop in blood pressure, and you totally avoid that dangerous spike in heart rate.
This brings us to a super important safety point. So, whether you're using an agonist like clonidine or a beta blocker for a long time, what do you think is going to happen if you just suddenly stop it?
Well, the body is smart. It adapts. When a receptor is constantly being blocked, the body just makes more of them to try and get a signal through. We call that upregulation. Now, if you suddenly stop the drug, all those extra hungry receptors are exposed to the body's natural adrenaline, and boom, you get a massive sympathetic surge. This can cause severe rebound hypertension, tachycardia. It's a really vital concept to remember.
Okay, let's shift gears now to agents designed specifically to lower blood pressure, usually in an emergency. We're going to start with one of the most powerful, fastest-acting drugs we have, but, and this is a big but, it comes with a pretty serious hidden danger.
Sodium nitroprusside is just an incredibly effective tool. When a patient's blood pressure is through the roof, this stuff works within seconds to relax both arteries and veins. It brings the pressure down fast and gives you this beautiful minute-to-minute control.
So sounds perfect, right? It's fast, powerful, easy to dial in. Well, here's the problem. The way our body breaks this drug down, it creates a byproduct that is literally a potent poison. See, as nitroprusside gets metabolized, it releases cyanide, and the very first clue you're in trouble is something called tachyphylaxis. You find yourself needing to give more and more and more of the drug just to get the same effect. That is a huge red flag. If you don't catch it, you'll start to see metabolic acidosis and arrhythmias, as that cyanide starts shutting down the cell's ability to use oxygen.
But here's the good news. We have specific antidotes that can pull you out of this mess. Sodium thiosulfate helps the body convert the cyanide into a much less toxic compound. And then there's hydroxycobalamin, which is basically a form of vitamin B12 that just goes in, binds directly to the cyanide, and neutralizes it. It's a lifesaver.
Of course, nitroprusside isn't our only choice. We've also got drugs like nitroglycerin and hydralazine, and they work in totally different ways. Nitroglycerin mainly hits the veins, which reduces preload. That's the amount of blood filling the heart. It's perfect for a heart in failure. Hydralazine, on the other hand, works on the arteries, reducing afterload, the resistance the heart has to pump against. It's effective, but you guessed it, it can cause that reflex tachycardia we talked about. Okay, for our final section, let's zoom way in, from the whole system down to the local level.
how do we actually completely, but reversibly, stop a nerve from firing to numb up just one specific part of the body?
The whole secret lies with these things called voltage-gated sodium channels. Just think of them as the ignition switch for a nerve impulse. For that nerve to fire, these little gates have to swing open and let sodium ions rush in. Local anesthetics are basically gatekeepers. They jam the lock, keep that gate shut, and prevent the nerve from ever getting started.
What's so fascinating is that these channels are always cycling through 3 different states. And local anesthetics are really clever. They don't just bind any time. They preferentially bind to the channel when it's in the inactivated state, which is right after it's fired. By grabbing on right then, they trap the channel in this off position, so it can't reset and fire again.
Now, not all local anesthetics are created equal. They fall into 2 main chemical classes, esters and amides. And this difference is absolutely crucial. Esters get broken down right there in the blood by plasma lipase enzymes. Amides, though, they have to be sent all the way to the liver to be processed. And this isn't just trivia. It has huge clinical implications. If your patient has liver disease, they can't clear amides very well, which increases the risk of toxicity. Plus, the breakdown product of many esters, PABA, is a known allergen, while true allergies to amides are incredibly rare. If too much of this stuff gets into the bloodstream, it causes a really predictable and dangerous cascade of events we call LAST. It always starts with these subtle central nervous system signs, ringing in the ears, a weird numbness around the mouth, maybe a metallic taste. If you don't catch it right then, it escalates quickly to agitation and seizures, and then the final step is devastating cardiovascular collapse.
And we have to stop and single out one drug in particular here, bupivacaine. This drug is notorious for its cardiotoxicity. The reason is that it binds so tightly to the sodium channels in the heart, making it incredibly difficult to resuscitate someone from a bupivacaine-induced cardiac arrest. This is something everyone who does regional anesthesia needs to have burned into their brain.
Thankfully, we now have an amazing and super effective antidote for LAST. It's called intravenous lipid emulsion therapy. The way it works is by creating what we call a lipid sink. See, local anesthetics are fat-soluble, so when you infuse these lipids, they literally just soak up the drug right out of the plasma, pulling it away from the heart and brain and allowing those tissues to start working again. It is a true life-saving treatment. So let's boil all this down. What are the absolute must-know takeaways? Number 1. Adrenergic agents give you precise control, but you have to know which receptor you're targeting. Number 2, never ever abruptly stop long-term beta blockers or alpha-2 agonists. That rebound surge is for real. 3, nitroprusside is powerful, but you have to watch for tachyphylaxis as your first sign of cyanide toxicity. 4, know the early CNS signs of local anesthetic toxicity. It could stop a catastrophe. And finally, number 5, respect bupivacaine's cardiotoxicity and know that lipid emulsion is the antidote for LAST.
We've covered a ton of ground, all the way from system-wide control down to a single ion channel. So as we wrap this up, I want you to just think for a second, which of these principles, whether it's receptor upregulation, a drug's hidden dark side, or a life-saving antidote, is going to have the biggest impact on how you take care of your patients from now on? Thanks for joining me.